This program is brought to you by Emory University.
Good morning. Thank you for joining us for Emory Cardiology Grand Rounds. It's my distinct pleasure and privilege to introduce Dr. Amit Amin. Dr. Amin is an interventional cardiologist at Washington University in St. Louis, Missouri, where he serves as the assistant professor of medicine at WashU, and he also has recently gained the title of the medical director for heart and vascular outcomes and quality. Dr. Amin did his general cardiology and interventional cardiology training at St. Luke's Hospital at Mid-America Heart Institute in Kansas City, Missouri, and then he subsequently completed a 3-year research fellowship as an American Heart Association Outcomes Fellow, and he earned a Master's of Science in Clinical Research degree under the mentorship of John Spertus at Mid-America Heart Institute. And he then, in 2012, joined the faculty at Washington University. And Amit has really grown and developed an exciting and productive career as of course, a clinical practicing interventional cardiologist, but also as a health outcomes researcher and scientist with a lot of notable publications in this field, including in JAMA and JAMA Cardiology and other such journals. And he has really demonstrated how one can translate evidence into practice in the cath lab in terms of outcomes, how you gain buy-in from your colleagues, and he has a tremendous amount of passion, a real mind for this, and he's he's really emerging as sort of a national thought leader in this, and he's a great friend and colleague in this area. So it's my great pleasure to have you. Amit, thanks so much for joining us, and go from here.
Avi, it's such a pleasure to be here today. It's such an elite crowd, and I'd love to present my thoughts and ideas on cost and quality and value-driven care in the cath lab. Before I get started, though, for the fellows, I want to let you in on a secret, though. When I was a fellow and I heard the words cost or quality, my mind would blank over and I heard nothing after that. Because most of those research presentations or studies were sort of very non-clinical. And during my fellowship years as I trained and in my early years at Barnes-Jewish Hospital, a realization dawned upon me that these are extremely clinical issues, and there is no one better than us clinicians to really grab the bull by the horns and tackle these head on so that we achieve where we want to go with value-driven care. So with that introduction, allow me to present some of the work we have done in the academic space, as well as what we have achieved at Barnes-Jewish Hospital. Here are my disclosures. So I am very heavily biased that the ultimate goal of all research, whether basic science or translational research, is to ultimately improve patient outcomes. And so outcomes research is, I think, like the culmination of, it's like the final common pathway of all research. And all our efforts and goals as clinicians are focused towards improving patient outcomes. However, therein lies the challenge. The translation of bench to bedside is easier said than done. And I think it is because of the fact that the basic science studies or the randomized trials, which evaluated these therapies or drugs or devices, are in a very narrow selected population. But when the rubber hits the road and we are taking care of patients, the penumbra widens, and we as clinicians have the challenge of applying that same knowledge to patients that really didn't meet that criteria or didn't fit those randomized trials. And that's where the variation in clinical care comes. And so what I'd like to show is, you have a similar population as ours. What I'd like to do is illustrate some of these challenges in care. So here was a 87-year-old Caucasian lady who had lots of comorbidities, who was referred for an elective PCI. She came walking in on door with angina. She had a high risk for bleeding, and we should have used multiple bleeding avoidance therapies. A complex PCI to LAD and diag was required. Unfortunately, no bleeding avoidance therapies were used. We didn't use radial access, no closure devices were used. And we can argue a little bit about Bivalirudin, and I have some slides on Bival subsequently. In any case, during the PCI, she started going hypotensive, her legs started blowing up, was the left leg, and she had the combination of a massive GI bleed, and you can see the melanotic stool, as well as a large left groin hematoma, which was the site of access. She struggled for days in the CCU, and at the end of 2 weeks, when she finally left home alive, to her this just wasn't worth it for an elective procedure for just angina. Here's another example of a 61-year-old lady who had, again, lots of comorbidities, who came in with a non-STEMI. Her AKI risk was high. We predict how much dye can be safely used, and we exceeded that amount because she had 3-vessel coronary disease, and we proceeded with an FFR-guided PCI to multiple vessels. She subsequently developed acute kidney injury, became anuric, was started on hemodialysis. It doesn't stop there. She developed a stroke afterwards. Her EF dropped. She was discharged alive, but has very poor quality of life and keeps coming in and out of the hospital with frequent readmissions for dialysis-related problems and heart failure as well as stroke. So it is cases like these, which, in my opinion, are at the penumbra of, where randomized trial data doesn't really apply, that we have a big challenge. Another phenomenon that, in my limited time as an interventional cardiologist since fellowship up until now, that I've been, noticing quite dramatically is that the complexity of PCI patients that we face is changing very, very rapidly. Here is a study we looked at from Premier, and this is a paper that is being reviewed by co-authors and will be submitted very soon. We looked at traditional risk factors of diabetes, hyperlipidemia, and hypertension on the left-hand side, and the more comorbid conditions like CHF and CKD, PVD, COPD on the right-hand side. And we see a uniform trend of increasing comorbidity burden. This was data until 2012, and we've subsequently appended that data to 2014. And this is a figure from that paper, which looks at the temporal trends in the comorbid conditions. And in this study, we found that there was a rather rapid and exponential increase in some of these comorbidities, which was associated with an increasing trend towards hospital mortality. We specifically looked at the combination of heart failure, COPD, and chronic kidney disease, renal disease. RD stands for renal disease. And these are, those subgroups, and there's a uniform pattern. Well, firstly, these are very high in prevalence, and the adjusted prevalence is on the y-axis, and the combination of these comorbidities also appear to be rapidly increasing over time. This comorbidity burden has a direct impact on outcomes such as mortality and bleeding, and as the number of comorbidities go up, in this analyses, there was a exponential increase in their likelihood of in-hospital death. Not only does it have an impact on outcomes, it has an impact on length of stay as well as cost, and so this data allowed us to look at cost. And so the cost of caring for these patients is extremely high. And so again, that is the challenge of translation of some of these things to from bench to bedside, and therefore we see a large variation in clinical practice and inconsistent and poor outcomes in this kind of patient population. And so what are some of the instances of this variation in clinical care? Here was a paper that Rich Bach and myself, we conducted this study from NCDR Cath PCI registry of 1.3 million patients, looking at the variation in contrast volume by physicians and the variation in acute kidney injury. And in this study, allow me to orient you to the graph. On the x-axis are the physicians in ascending order of their contrast volume used, and on the y-axis is their mean contrast volume. We included physicians performing more than 75 PCIs a year, and in this study we found that there were some physicians who were using less than 100 cc's on an average, but there were others who were using close to 300, 400, 500 cc's on an average. Performing PCI. Now these are real data. I mean, they come with limitations around the accuracy of the data, but nonetheless, this is what the NCDR Cath PCI registry reflects. The variation in AKI translated into a variation in their AKI event rate as well. Again, on the x-axis are those same physicians, and we see some physicians with extremely low rates of AKI on an average, while there were others in the range of 15 to 20, 25% average rate of AKI. And if you really put this in perspective, 1 in 4 or 1 in 5 of their patients are developing acute kidney injury, perhaps unknown to the physician taking care of these patients. Here's a remarkable slide from this paper, and what we did was we divided that entire 1.3 million PCI population by deciles of AKI risk. And so on the x-axis are those 10 deciles, 1 being the lowest risk and 10 being the highest risk, so the increasing order of AKI. And on the y-axis is the mean contrast volume being used in across these deciles. And we saw a nearly flat line until the 9th or the 10th decile. There was absolutely no reduction in the amount of dye being used, and only in the highest risk decile there was a mere 16 cc's reduction in contrast volume being used. In other words, implying that the average physician in the United States today in the Cath PCI registry is focused on perhaps angiographic outcomes and not really focusing on AKI risk. I'd like to share some data from our own hospital and hospital system. This is data from the BJC system, and the individual operators de-identified are scrambled on the x-axis with the average contrast volume. And you can see that same variation that is reflected in national data also reflect in our hospital system data as well. This is their rate of AKI. I'm sorry, the x-axis is not labeled, but this is their rate of AKI, and again we see the same variation being reflected. This is the rate of bleeding complications, and there are some operators with extremely high rate of bleeding complications, while some are quite low, and the same variation is seen across the operators. Some key processes like radial access, and this is a slide showing radial access. We are right about at average radial access right now, but because this data spans 2009 through 2017, we see the low prevalence of radial access as well as a lot of variation. These processes not only impact outcomes, they also impact costs. Here is another hospital cost data looking at the variation in the hospital's costs of PCI. So this is what the hospital is paying or is spending rather, to take care of these patients. And again, there are some low-cost hospitals and some hospitals whose care processes are inefficient, that we see an extremely large degree of variation. In this analysis, we adjusted for patients' comorbidities, their risk of complications, and other confounders of cost, including the number of stents used, for example. And we found that almost a third of the variation in cost was explained not by patient comorbidities, but by hospital processes. We had in terms of statistics, we had a random effect for the hospital site, and a large part of the variation was directly attributable to the hospital, even after adjusting for patient comorbidities or the number of stents used and other confounders. Such variation in care in the current era of healthcare reform is really, an aspect that could be easily improved upon. As you are well aware, CMS, whether it's Donald Trump at the helm or a Democratic government, they do have a very aggressive goal of continuing to cut down costs. And the general trend over the last few years that we have seen is that there is a shift in the risk from the provider onto the from the payer onto the hospitals or providers, and whether it's bundled payments or value-based purchasing, any of these programs are inherently designed so that hospitals assume more risk and then the payer assumes less risk, and it is not only for outcomes but also for cost. Big places like Emory or Barnes Hospital do have some leeway, but there are many community hospitals who don't have that leeway. And this is MedPAC report to Congress a couple of years ago, looking at the entire population of the country's hospitals. And this is a slide showing the overall hospital Medicare margins, whether it's inpatient care or outpatient care. This is not limited to PCI, it's overall care. But most hospitals work on a negative margins when it comes to Medicare patients, whether it's inpatient or outpatient. And so when we were evaluating, when we were being considered for bundled payments, we started evaluating one of our hospitals for the risk that they would assume. And this is a slide. This is sort of an average community hospital, about 400 PCIs, 250 AMIs, 150 cabbages. And depending on what the outcomes are and specifics related to the bundle, the risk can be substantial. It could run from hundreds of $1,000s close to $1 million. And with the margins I showed you, it could be a game changer for many hospitals. Here's our administrator and myself, talking about the budgets, and it's a continuously moving target, and every year we face new challenges as we negotiate contracts with existing payers. So it is quite challenging to provide high-value care when risk and complexity is increasing and we face these reimbursement challenges. So it's a clinical issue as well as sort of an administrative issue. And so the real solution is to provide high-value care, and by high-value care, value is defined as health outcomes that matter to patients at a lower cost of delivering those same outcomes. And this is the fundamental goal and purpose of healthcare, and that is the only goal of healthcare. So improving value is the only real solution. So let me take a little diversion on some of the things that could add value to angioplasty care. I need not emphasize to this group the clinical benefit of radial access for PCI. Here are some meta-analysis, and then the Matrix trial showed actually a reduction in mortality with radial angioplasty. And so, my interpretation of these decades of radial literature, and perhaps the only interpretation, is that in patients undergoing ACS, there is a causal association, causal relationship of reducing bleeding and mortality, and the reduction in mortality is through reduction in major bleeding. We have done some work on the cost side of radial angioplasty, and when I was still a fellow at Mahi, Steve Marceau and myself, we used data from 5 hospitals. These were large volume hospitals, and looked at their cost and outcomes with a simple stratification of radial or femoral access used. And in this paper, we found that there was about $830 difference favoring radial angioplasty. At that time, we said this is an initial study. It's a signal from these 5 hospitals. We didn't really stratify it by what is related, or what is the association of this reduction in bleeding. So we took this initial study and then we expanded it to the entire NCDR Cath PCI registry, and this is a paper that was published recently. We used the NCDR Cath PCI registry and merged it with Medicare, so that not only do you have the in-hospital outcomes, but now you also have the costs. And so the costs in this paper are again from the hospital's perspective. We are not concerned about the payer's perspective, meaning what is spent in taking care of these PCI patients by hospitals. And so here's a figure from that paper. This was an elective PCI population. We excluded all non-STEMIs and STEMIs. There are some complex PCIs like elective PCIs like CTOs, and those were excluded as well. The reviewers made sure we excluded anyone undergoing PCI with an Impella or balloon pump, or those who were intubated. And then furthermore, we stratified these patients and risk adjusted them with not 1 but 2 propensity scores, one predicting radial access, one predicting same-day discharge. So it's really a very rigorous analysis, and it took us a while to get this paper accepted. What we did in this study is we divided our patient population by radial, femoral, inpatient, outpatient, same day and non-same day. And what's remarkable is for the exact same procedure, the traditional pathway of femoral inpatient, not same day PCI cost about $17,000. But when we looked at radial outpatient and going home same day, it costs $9,000. Now these are unadjusted differences. After propensity matching for radial and same day discharge, so that it's truly comparing apples to apples, we found that there was a $3,600 difference favoring radial same day discharge over the traditional pathway. And in the paper we have a table of the adjusted costs for all of the various pathways. So you can take a look at that too. In this study, we also projected some back-of-the-envelope calculations for a hospital converting from one pathway to the other. So on the x-axis is that percent conversion. On the y-axis are the estimated cost savings for a hospital performing about 1,000 elective PCI procedures annually when converting from one pathway to the other. And the 3 bars, the red, blue, and green bars, are the pathways. We found in this study that discharging patients same day was associated with huge cost savings, and especially radial same day was associated with even greater cost savings. What can be seen on the x-axis is for even a small conversion from 35 to 40-50%, the cost savings are to the tune of hundreds of thousands of dollars. The same is also reflected in our data. I have labeled all of the y-axis as somehow during the file conversion, the labels have gone behind the figure. But on the y-axis here is the rate of bleeding across the operators in the BJC system, and we see the same reflection that was seen in other trials and other observational studies, that as radial axis improves, there is a reduction in the rate of bleeding complications across operators. I want to take a few minutes to talk about Bivalirudin versus heparin. This is an area of really extremely large controversy. There are some diehard Bivalirudin fans out there, and there are some who use heparin. I am not by any means a high Bivalirudin user. When I last looked at my data, I was about 70% heparin for PCI. I use about 25 to 30% Bivalirudin. And I thought I'd just take a few minutes to talk about this intense debate on Bivalirudin versus heparin. So this was a survey conducted by Sky, and I think this was a sample of about 70 interventionists. And the question that was asked to them is, in STEMI patients undergoing primary PCI with femoral access, what proportion should be treated with Bivalirudin? And there was a very wide variation in the responses. And I think the Europeans have also conducted a similar survey. I'm not sure if it's already in print or not, but there is a wide variation in the United States. And the trial that really ignited this debate was the HEAT primary PCI trial, which was a STEMI trial from the United Kingdom. Was a contemporary trial with over 90% second generation P2Y12 of prasugrel and ticagrelor. Plavix was used in 10-15% of the cases. GPI appropriately was in the range of 10 to 15%, and radial access was 80%. Interestingly, PCI was only performed in about 80-85% of the cases, which hardly occurs in US practice. And there was a 3% absolute risk increase favoring heparin, 3% increase in the Bivalirudin arm, with a relative risk of 1.5, which in turn was driven by reinfarction and TLR, which in turn was driven by an incredibly high rate of stent thrombosis of 3.4% versus 0.9%. And there was also a scrutiny of the door-to-balloon times, and here are the door-to-balloon times of 29 minutes in HEAT primary PCI, something that is extremely hard to achieve in everyday practice. So if you really put that 29 minutes into perspective, it takes at least 10 minutes, maybe 15 minutes for the patient to arrive to the ER door and get on the CAT table, no matter how fast you are. And that's when Bivalirudin is started at the time of PCI. And because your door-to-balloon time is only 30 minutes, I'm estimating infusion time of less than 30 minutes on an average across this population. Even if ticagrelor or prasugrel have been used to 90% in this trial, there is this large window of vulnerability where no matter which anticoagulant is used, there will be a higher rate of stent thrombosis. And with Bival infusions and the short half-life of Bival, I think it is no surprise that HEAT primary PCI showed such a high rate of stent thrombosis. So my personal take on prior trials of Bivalirudin and HEAT primary PCI is that the prior trials of Bivalirudin with glycoprotein 2B3 inhibitors were rigged in favor of Bivalirudin to show a difference in bleeding complications. But this trial perhaps was rigged in the opposite direction to show an increase in the rate of stent thrombosis. This is just some PK/PD data to show that 1 hour door-to-balloon time, there is no intraprocedural effect, and there is a delayed peak effect. And this is a scenario that many of us see. Here's a patient with a mid-LAD stent, primary PCI with their dual antiplatelet pills not even beginning to get absorbed. There was a remarkably low rate of bleeding events in this trial, but they had an 82% radial access. There's more and more literature coming out that perhaps Bivalirudin is not really needed when you have a very high rate of radial access. And there are a lot of observational studies now, and this trial confirms the same as well. And GPI use was quite low. Here is some data on the antithrombin matrix study, which looked at Bivalirudin and unfractionated heparin as well. Again, 2B3 inhibitor, a rather contemporary study with 10 to 15% usage of 2B3A, and because of the randomization, about 40% usage of Bivalirudin. There was no difference in the co-primary endpoint of major adverse cardiac events or NACE, which include bleeding. But if you break up two important outcomes, which is bleeding and mortality, no matter what scale you looked at, there was a difference in reduced bleeding. And so the trial, strictly speaking, was a negative trial or didn't show a difference for Bivalirudin versus heparin. But if you look at bleeding by any scale in a randomized comparison, there was a reduction. And there was also a reduction in all-cause mortality, which is reflected across prior trials. That was randomized data. We are judged according to the NCDR Cath PCI bleeding definition. And this is an analysis by Dmitry Baklanov looking at a large population, close to 500,000 PCI patients by vascular access and anticoagulation. And the combination of femoral access with closure devices and Bivalirudin had the highest rate of bleeding complication, followed by radial access with heparin, and the lowest was radial access with Bivalirudin with a non-access site or access site bleeding. This is, I think, a study that was just published last week by Bobby A. And colleagues. Bobby is the senior author from now moved to, I think he's moved to Harvard, Beth Israel. This was an instrumental variable analysis, and IV analysis is as close to a randomized comparison in a large scale. What they are looking at are trends of change, shift in the usage patterns of Bivalirudin, and based on that change, they are attributing in as close to a causal framework with the selection biases almost completely mitigated. What we can see in this study is that in hospital bleeding, before and after adjustment for glycoprotein inhibitor therapy, there was a 1% absolute reduction in bleeding complications, especially when femoral access was used. And when radial access was used, that benefit was completely negated. So perhaps suggesting that in an all-comer population with all the comorbidities and complexities that we see in everyday practice, when femoral access is being used, there may be a benefit of using Bivalirudin in for reduced bleeding. Here are data from our own system. Again, the average rate of Bivalirudin is on the x-axis and the bleeding rate on the y-axis. And this is a regression line fit to about 25,000 PCIs showing a similar trend as was seen in the randomized trials. We tried to replicate Dimitri's analyses. And in Barn Jewish Hospital, about 10,000 PCIs, when no bleeding avoidance therapies were used, it was the highest rate of bleeding. And then you can see when you stack on bleeding avoidance therapies one on top of the other, there is a incremental benefit towards reduced bleeding. This whole concept of treating according to risk is also reflected in the cause data. This was a analysis that Elizabeth Magnuson and myself performed from the CATH PCI registry, and this is a modeling study. It's a cost effectiveness of targeting patients undergoing PCI for Bivalirudin versus heparin monotherapy. So GPIs were eliminated, and it is the comparison that is of interest to us. And back then, Bivalirudin was not generic, and we modeled those curves. And so when bleeding risk goes high, we found that the cost effectiveness, the incremental cost per bleed prevented, reduces at high risks of bleeding. Bivalirudin is now generic, so it costs even lower. So perhaps suggesting that it leads to improved outcomes and lower cost in the highest risk groups. So how do we take all these data and apply to our everyday practice? This was a study that from NCDR that Steve and I performed back in 2010, looking at the association of bleeding avoidance strategies with the baseline risk of bleeding. And in this study, we coined the term risk treatment paradox. Back then, Bivalirudin was not so controversial, and this is a paper study figure from that study. We looked at the risk strata of low, moderate, and high risk, and we found that when risk goes high, on an average, use of Bivalirudin goes low. So the highest bleeding risk patients are least likely to receive bleeding avoidance therapies. Bobby and colleagues subsequently also performed the same for transradial access, and they found that those at the highest risk for vascular complications were treated the least with radial access. Our cath lab was no different. This is our cath lab data also exhibiting this very prominent risk treatment paradox, and these are older data from 2012. Bivalirudin closure devices and radial access, they all show that risk treatment paradox and radial access was extremely low. So at Barnes-Jewish Hospital, we have a sort of complex referral pattern. We are in the center of the city. We only get cases which are referred to us from other surrounding hospitals. We are a VAD program, like yourself. And so the comorbidity burden and complexity burden is befitting that of a tertiary academic medical center. And so this is our average bleeding rate across many quarters before we got started. It was in the range of 7 to 10%. And it had oscillated at this very high rate of bleeding when the NCDR registry average at that time was 4.5%. So at least twice as high and 4 times as high as the best hospital in the country. So what we have done is we have used a patient-centered approach in our cath lab. What we found that of that 8 to 10% bleeding rate, almost all of the bleeds were occurring in the moderate and high risk group. So we decided to target that moderate and high risk group through a health IT solution, and the goal was to achieve high reliability every case, every time. Now, expert clinicians, like the ones we have as well as the ones here, we know someone is at high risk for bleeding. However, it is that explicit recognition of bleeding risk being high that alters something within fellows, within the attendings taking care of the patient, and it leads to a downstream effect that I can share with you. What we do is, and this is a model for risk of AKI or dialysis. We have flipped the AKI risk prediction model around so that we can predict on an individualized basis the amount of dye that this person in front of you, not a registry average, can safely tolerate before they develop AKI. And then we have also done process improvement for processes such as hydration. It's uniform across the board. Clinicians vary around it by reducing the amount of hydration being used for heart failure patients or those with valve disease, but the process remains the same for all patients. And so here is a document that our interventionists review every case, every time. There are some key variables on the top left-hand corner, such as creatinine, hemoglobin, GFR, and ejection fraction. We are tracking 3 or 4 different things. One is the risk of bleeding, the other is risk of mortality, whether the case is appropriate or not. We did have a problem with a very high rate of inappropriate elective PCI. Not that we were doing inappropriate cases, but the documentation did not support the acuity of the patient. And then acute kidney injury. Here is sort of estimate of the contrast volume being used. Now this is an estimate, but once we see this and review it in the cath lab holding area before the case, then there is a real honest effort from all the entire team taking care of the patient to reduce or stay within that limit. So I think this is the entire essence of patient-centered care, and the IOM defines patient-centered care, care that is responsive to the individual patient's needs and values, ensuring that these values and needs, these clinical needs, guide all clinical decisions. Just showing that one decision aid isn't enough, we feel. We do have core monthly meetings that Dr. Mann, our chair, and the interventionist and the hospital chair, we sit down and review key processes. Not only is there review of outcomes, but there is a very close scrutiny and review of key processes. And so I don't expect you to read this, but what we are doing is, here is one physician compared to the other peers, as well as national benchmarks from the NCDR Cath PCI registry. And we focus on the processes, key processes. Was contrast limit exceeded in high-risk cases? Was hydration performed? Were bleeding avoidance therapies used in these high-risk cases? And then the use is compared against national benchmarks as well as peers. What this has allowed us to do is set up sort of a friendly competition between us, the interventionists, in a very collegial and diplomatic manner, because these are all de-identified data. So I'd like to share with you what the impact on outcomes and cost has been. This is our percentage of radial access increasing rapidly. I think we are still lagging behind, and we are sort of at the national average. We could be better, but it's increasing very rapidly. This is a complex slide. Please allow me to walk you through this. There are 2 line graphs here. In the purple line, on the y-axis on the left-hand side is the proportion with bleeding events, so it's a bleeding rate. And these are hard events, meaning this is not risk-adjusted bleeding. These are patients who bled according to the NCDR definition. And then I talked to you about the risk treatment paradox. And so the line in red shows a declining trend of reversing that risk treatment paradox, meaning bleeding avoidance strategies are used in a more aligned or risk concordant manner. And as the risk treatment paradox reduced, there was also a reduction in bleeding. And this is a roundabout way of doing it, but to ask the question, are these 2 lines independent of each other? We did a test of independent decrements, and there is, p-value was not statistically significant, meaning the null hypothesis is rejected, meaning that these 2 lines seem to be linked together. Now it's an association, can be interpreted in a causal framework, so this is not causation, but it certainly seems to suggest that as we treat patients in a more risk-aligned manner, it reduces bleeding. Here's our bleeding event rate. We started at 8 to 10%, and now we are consistently bouncing around the 75th percentile. There are some operators who are well below the 90th percentile, and when we look at their data, these are operators who are using these bleeding avoidance treatments in a very risk-aligned manner, or risk-concordant manner. But we do have some variation in our practice. Nonetheless, very consistent data. I'd just like to take a minute to put this into perspective. Trials of radial access or other bleeding avoidance therapies have shown a 1 to maybe a 3% reduction in bleeding. This is a whopping 6% absolute risk reduction with, now again, not a randomized trial, but the numbers and the consistency has sort of stood the test of time, at least at our institution. Here's a graph showing the contrast volume in cc's on the y-axis across years. Again, we were in the range of 200 to 250 on an average, and we are now in the 150 range. So again, a 30-40% reduction in the average amount of contrast being used when case complexity remains unchanged or perhaps even increasing. Our AKI events have also reduced. We were at 7.75 in 2012, and now we are again bouncing around the 75th to the 90th percentile. There was one quarter we went above the 90th percentile. We are seeing a late downstream effect also on as these complications reduce. There has been a reduction in mortality, and for the last few quarters, and these are older data, I need to update this slide, we have consistently remained above the 90th percentile. This is a slide showing our inappropriateness, PCI inappropriateness for elective PCI. Again, it has this sort of risk stratification at the time of the angioplasty. And by the way, we have included that decision aid in the timeout process. So at the timeout, before the case starts, the attending is aware that the case is inappropriate, and then all it has done is alert us to the documentation provided. Was there appropriate documentation of symptoms? Was the stress test appropriately documented to convey the risk and look more carefully at the medications? So it has led to this remarkable increase in PCI appropriateness. The way our system is set up, there are the UHC, Blue Cross Blue Shield, it's a large private payer. The reimbursement rate for the hospital when inappropriate elective PCI rates are below 5% is about 20 to 30% higher than what it was in 2012, because that is one of the UHC anthem metrics of 90th percentile on PCI inappropriateness. Patients aren't bleeding, they aren't having AKI. Why keep them in the hospital? Here's a very simplistic same-day discharge model that we've started at Barn Jewish Hospital. We proactively identify these risks, we mitigate them, and then if the interventionists feel that the case went really well, even if they have diabetes and COPD and heart failure, we discharge them home. And so here's our rate of same-day discharge among the elective population. It's gone above 70%, and I think our unique patient-centered approach has allowed us to discharge even the complex patients home. And these data are accepted but not yet out in print. Here's a slide showing that, again, like I mentioned, whether graft cases or those with diabetes, CVD, PVD, or long lesions, type C lesions, they are going home. We track patient satisfaction, and we've also reported this in our paper, but the patients who go home same day, just as the randomized trial data show, are extremely satisfied and happy with the care, and have, on our survey, shown extremely satisfied or excellent care. We have collaborated with our finance division. I showed you some of the NCDR slides. We looked at our own cost data as well. And these are 4 buckets of variable cost, fixed operating cost, total variable operating cost, total case cost, and total operating costs. And no matter which bucket you look at, there's a quite dramatic reduction in the cost from the hospital perspective, the spend, favoring same-day discharge versus not same-day discharge for elective population. And here's a paper from that figure, again showing those 3 buckets, but a 35 to 45% reduction if you look at which bucket you're looking at in a reduction in cost. So, some of the lessons we've learned at Barnes-Jewish Hospital, I think 4 key elements are needed for this kind of change. I cannot overemphasize Dr. Mann's role and our cath lab director, Jas Singh's role, and the hospital leadership, Patty Crimmins-Rita's role in engaging the physicians, elevating this, and making sure that, the processes we decide as a group are implemented successfully. We have developed a very robust data infrastructure. We have complete faith in the integrity and honesty of the NCDR data that our data managers collect. I was telling your Mary about our Mary. Her name is also Mary Caruso, and she does just a phenomenal job and probably competes with you on the knowledge and how these outcomes are adjudicated and reported to NCDR. Some of the science behind it, and it seems fuzzy science, but it's really an implementation or application of the randomized data and some of the epidemiologic principles of treating according to risk that we have applied and serve as the framework on the basis of which we have made these changes. And then the hospital has been very kind to dedicate the resources that are needed to make this a successful project. I'd like to just show you a case example. Now this is an extreme case, but they do come our way, and this was a lady who was 86, lots of comorbidities, quite frail. I have a picture of her frail arm down there. That's the eyeball test of frailty. And she had STT depressions, and she came in with a non-STEMI unstable angina, and she didn't want to undergo CABG at all. So according to a formal pre-procedure risk assessment, she was extremely high risk for mortality, very high risk for AKI. She could only use 124 cc's of dye. She was extremely high risk for bleeding. And based on this, we decided to go radial. She had a lot of subclavian tortuosity and small vessels. Everything was extremely calcified. Here's a picture of her left main, and not only does it show a very high degree of calcium at the left main bifurcation, but I'd also like the fellows to appreciate that not much dye is effluxing out of the guide and the left main. So again, a very careful approach to minimizing dye while taking care of her anatomic complexity. She had a proximal LAD, diag 1, diag 2 trifurcation lesion with TIMI2 flow in the distal LAD, which was the source of her problem, as was the left main and ostial circ. This is a 3-hour later rotablation using a 6 French system. Please note we didn't revascularize all the diags. This is simply fixing her most potent vessels, left main, LAD, and ostial circ. And we used 100 cc's of dye. There was no bleeding, no AKI. Her angina is resolved. She's now undergoing cardiac rehab. Are the diags ischemic? They absolutely are, but she's able to tolerate that and has done well for the past couple of years. I see her regularly in my clinic. So, this to me is this transition towards value, not just doing case after case, but making sure that every case has a consistent outcome every time, and this is fulfilling the goal of value and value-driven healthcare today. I read this book recently, and a line in this book caught my eye, that mistakes will occur, and it is not reasonable to ask for perfection, but it is reasonable to ask that we never cease to aim for it. And so this is by Atul Gawande in a book called Complications, and I thought how relevant that is to what we are doing at WashU Bonjesh Hospital. So that's all I have. I think I'll stop here. I'm right at the 8:30 mark, and see if there are any questions or comments I can answer.
What happened to your low-risk patients if you applied the risk avoidance approach to them? I mean, why deny them that?
Why deny them that? What a wonderful question. Yeah. So the question is, why shouldn't we apply the risk avoidance strategies to the low-risk patients? And it's really a very insightful question. And I base my answer on an epidemiologic principle. For a therapy or treatment or drug or device with a fixed relative risk reduction, so if radial access reduces bleeding by 40%, for example, across the continuum of risk, as risk goes high, the absolute benefit for a fixed relative risk reduction, for a increase in their baseline risk, the absolute benefit is much higher in the higher risk group. So in the low risk group, by extension, it makes no difference, or would make little difference if you went groin or you went radial. It's pretty easy to go radial, it's pretty easy to go groin in the 45-year-old young man. And so the difference you would see would not be much. And our goal was to focus on the moderate and high risk based on these principles. I, for one, applied to everyone. So, whether it's low risk or high risk, I go radial on everyone. But in a busy practice, if someone wanted to save time and want to do the low risk cases, groin, and knock them out one after the other, while spending more time on the higher risk patients, then perhaps that could be a strategy and would lead to perhaps equivalent outcomes.
I thought it might be the cost, that if you try to apply this to the very
Absolutely.
low-risk group, you're going to have a higher cost. That's not necessary.
Yeah, absolutely.
I have a quick question.
Please.
Trying to push this here. There we are. Do you think clearly the contrast use is like radiation. We should use the lowest possible dose that you need. There's no reason to give more than necessary. And we all agree that there's a very clear relationship to contrast dose and acute kidney injury. But the real question is it the contrast or is it a marker of a problem? And how much of it is the contrast and how much is a marker? Clearly, when you do an intervention with 400 cc's of contrast, it's a marker of a tough intervention in a comorbid patient.
Absolutely.
And there are randomized trials out there that have actually increased the amount of contrast used and not seen acute renal failure, and that's the population of STEMI, where you take culprit vessel intervention versus doing multi-vessel intervention. And in the randomized data of multi-vessel intervention, where you stent 2 or 3 vessels, you obviously use more contrast, but you don't increase your renal failure by increasing contrast dose in that setting. And then there's some propensity match data in the STEMI population that if you look at the thrombolytic data where there's no contrast use, compare the acute renal failure to those that get contrast and PCI, they have similar acute renal failure.
Absolutely.
And so while contrast is clearly important, we should definitely, there's no reason to give more than necessary. When you look at this data, are we really just capturing unmeasured comorbidities? And I guess the final question then is the measurement of NCDR acute kidney injury really measuring the quality of a PCI procedure, or are we just looking at different variables of unmeasured confounders that we're not picking up?
What a terrific question. I'll say upfront that we see AKI even in the medically managed non-STEMI and unstable angina population. Right? We see it all the time. It's based on their heart failure. It's based on the medications that were started, Lasix and ACE inhibitors, or their cardiorenal kind of physiology, pathophysiology. If you look at the ACC-NCDR AKI risk prediction model, it does not have a very high C statistic in predicting AKI. So, as you correctly mentioned, there is a tremendous amount of variation in the baseline rate of AKI that this model only predicts to a certain degree. Having said that, there are some cases which are predictably reduced, that AKI is prevented. These are estimates of the renal, GFR. No one really knows for sure whether the GFR is compromised or not, or how much dye that can be used. I'll go about this in a slightly roundabout way, but we faced a real challenge in trying to identify the amount of safe contrast volume that can be used, and it required some very non-conventional statistical methods like ROC analyses to try and estimate how much dye can be safely used to prevent AKI, for an individualized patient. And let me tell you, those aren't perfect methods. From Blue Cross Blue Shield in Hitinder Gun's work from Michigan, they've used a 3 times eGFR as their top limit. Now that is a very conservative estimate of how much dye can be safely used. So for example, in an elderly diabetic with a creatinine of 2.8, with heart failure, for example, with a GFR of let's say 10-15, you can do only 25-30 cc's of dye. You can't even do a diagnostic cath in that much time. We've used ROC analyses to maximize the sensitivity and specificity trade-off in predicting AKI. So our estimates aren't very conservative, but they do favor the interventionist, and this is keeping the interventionist in mind so that we can maximize it. But I wholeheartedly agree with you that it's a marker of underlying complexity of disease. When we encounter such patients in our cath lab, and we know that dye limit is only, let's say, 30 cc's, then we do a limited angiogram if it's a bypass graft case, and I can see competitive filling in the LAD for the lima. Sometimes, I won't even shoot the lima. Now, one may argue that, you're not doing a full diagnostic, complete angiogram, but it is in the patient's favor, so that we can prevent that AKI. And then based on the limited angiogram, we can make a more informed decision of PCI versus, conservative management.
There are actually 2 questions from Midtown. Wissam Jabber is asking how much of the drop in your acute kidney injury and bleeding rates do you think is attributed to better documentation versus real changes in the non-adjusted outcome?
Another really, really good question. When we started implementing this ePrism system, it quickly opened our eyes to the existing gaps in our documentation. We thought at Barnes Hospital we have a pretty high quality program, but there is we observed a consistent 20 to 30% under documentation. And after many iterations of training, everyone who is involved in the documentation, including fellows as well as our cath lab nurses, we find that it is a quick validation that have we documented everything, and it has led to an improvement. So I have shown you, Dr. Jaber, I've shown you data on risk-adjusted metrics, but I've also shown you the raw events, the real events, the observed events. So there is an improvement on both sides of the O2E equation, the observed side and the expected side. So when you're looking at risk-adjusted metrics, now this is a guess, but I think 20% or 30% of the contribution is from improved documentation, and you can see the trends in real observed data as well. Does that answer your question?
One more from Midtown, and then we'll take any last question from here. Dr. Henry Lieberman is asking, what do you do with hydration when patients are added same day for cath, frequently in the afternoon? So if they're added for cath in the afternoon and you want to do same day hydration, how do you tackle that?
So as soon as the, firstly our hydration protocol, I'm happy to share it with you, isn't very burdensome. We are not mixing, bicarb or it's just saline. And we very quickly infuse a small amount of saline, 300 cc bolus, that's a soda can, for anyone, even as they're coming down. Let's say someone came in with a non-STEMI in the morning, they were evaluated by noon and are being sent down to the cath lab. Those patients, as the order gets placed, we have an automated, process of ordering hydration on everyone. Sometimes the fellow will reassess them and up or downgrade how much hydration is being given if they have heart failure or valve disease, but everyone gets some degree of hydration before and after. Measuring LVEDP during the case guides my subsequent hydration strategy. I know there's some data out there on measuring LVEDP to guide hydration, and sometimes we don't measure LVEDP and we just give a small amount of hydration for all patients. But obviously it's a clinical decision. I'd like to emphasize that the standardization is that there is a hydration protocol for every single patient. How much we change that or alter it based on individual clinical characteristics depends on the team taking care of that patient.
Just a comment. I think that what you've talked about here is taking a very intentional approach to trying to get better every day. And you show your defects that you had, you recognize what your defects were, and you try to put processes in place to improve upon that. And just for those in the room who don't know, we're in the middle of, or the beginning of trying to go through some process improvement. Monica Gertu is here, and she's helps with engineering, and you'll be seeing boards going up in our echo lab and cath lab and a variety of areas where we'll be talking about the days, what's going on that day, and how do we plan for that. And I'm very interested in hearing later about what you've done from a patient-centered approach as far as your process planning for these procedures. Are these patients who show up that day and then it's like, oh, by the way, they actually have an elevated creatinine, or do you know in advance and that type of thing? And I look forward to hearing about that today. But your talk is related to the interventional lab, but it applies to numerous things across medicine, and some of the things that you actually measure sometime and that you focus on, although those things may not specifically have an impact, the fact that you're taking an intentional approach towards improving can often improve other areas that you're involved in.
Yeah, you're absolutely right. Thanks for that insightful comment. We are seeing a downstream effect. I mean, one thing has led to the other, has led to one more, and we keep moving in the right direction.
One more comment. It's commonly said there's a resistance often in clinical circles to standardized care because they're concerned that it's going to take away your ability to innovate or vary according to the individual patient need. Can you comment on that? Because a lot of your work has been putting protocol structures in place, implementing. So how do you reconcile that view of standardization versus allowing for the art of medicine to occur?
I'll say it's quite the contrary, actually, because this patient-centered decision-making actually promotes that art of medicine in a more informed and formal decision framework. So many of my partners, we are on average 30-40% radial usage. We are on an average about 20% Bivalirudin. But there is variation in processes that we see, variation amongst operators. But all of them are making very informed decision making. So I will gently push back by saying that it does not remove that variation. In fact, it allows a very thorough evaluation of all those processes, which then allows operators to reevaluate in a very data-driven manner with the patient at the center of the focus.
That's terrific. Thank you very much for joining us this morning.
Thank you so much.
The preceding program is copyrighted by Emory University.